how you handle your vessels. Trust me, tracheal and also pharyngeal anastomosis is easier. It's not that difficult, but there are a few techniques that you can do. Okay, so all ready to continue? Okay, so let's get cracking. When would you consider a tracheal anastomosis? So tracheal anastomosis can be used whenever you want to do a tracheal resection and also anastomosis, TRA. It's a very specific ENT procedure. And do you all know when would you like to do a TRA? I'm expecting my ENT medical officer to answer this. What are the indications of a tracheal resection and also anastomosis?
Tracheal stenosis.
Tracheal stenosis, so you have a complete tracheal stenosis or a tracheal stenosis that is failed endoscopic treatment, right? Endoscopic dilatation. So then you consider resecting part of the trachea and also anastomosing the trachea. Of course, there are certain prerequisites to it. You have to, patient selection is very important. The patient must have good lung function, shouldn't be a smoker. Vocal cords ought to be functioning. You want to have a bilateral mobility of the vocal cords to reduce aspiration. So there are several prerequisite factors that needs to be considered before you do a tracheal resection and also anastomosis. In ENT, we do a tracheal resection and anastomosis for patients with cervical tracheal stenosis. Yeah. Sometimes in patients in trauma, where they have a shock trauma to the neck, whereby the trachea is transected. I've had 2 cases in my career so far. You may have to re-anastomose the trachea with or without a tracheostomy. Yeah? So whether you're doing a single stage without a tracheostomy or double stage with a tracheostomy, there are several factors to it that can be discussed later. Sometimes patients will require a laryngectomy. In a laryngectomy, you will remove the larynx and you'll bring the trachea out in the neck of the patient. So this will then create a tracheostoma. So you need to suture the trachea to the skin to form a tracheostoma. So before we start getting our hands dirty with the trachea, let's first understand the anatomy of the trachea. As you all can see, our trachea is a C-shaped cartilage. So the C-shaped cartilage is in the anterior bit of the trachea. It's in the form of a U. This cartilage gives the trachea its strength, so it prevents the trachea from collapsing. Unlike the esophagus, it's a collapsible structure. But at the posterior part of the trachea, as we all know, it's devoid of any cartilage, so we have the trachealis muscle. And the posterior part, which is the part of the trachealis muscle, posterior to it, we have the esophagus. So whenever we're doing a tracheal resection and also anastomosis, we have to be mindful to not traumatize the esophagus, which is lying posteriorly. So we have to separate the trachea from the esophagus at the tracheoesophageal groove. Now, to my ENT postgraduates, what are the important structure that lies at the tracheoesophageal groove? The recurrent laryngeal nerve. Yes, and how do you prevent yourself from injuring the recurrent laryngeal nerve when you're separating the trachea from the esophagus? Anybody? You. Shout out loud. Nerve monitor? No, not really. The main thing is you want to dissect as close as possible to the trachea. As long as you're dissecting as close as possible to the trachea, you're minimizing injury to the recurrent laryngeal nerve. Yeah? So you need to clear up the pretracheal fascia and dissect as close as possible on the trachea to reduce trauma to the recurrent laryngeal nerve. Alright? Okay, so our trachea is about 11 centimeters in length and diameter may vary between 2 to 2.5 centimeters, yeah, depending whether it's a large patient or if it's a male or a female patient. Usually a male will have a slightly larger trachea compared to a female. Okay, but whenever we do a tracheal anastomosis, we do an end-to-end anastomosis, meaning that we are suturing one end of the lumen to the other end of the lumen. We are suturing the proximal lumen to the distal lumen, right? And the sutures ought to be done through and through. That means you're not cutting it halfway through the mucosa or the serosa. You're cutting it. You're putting a needle through thread going inside in the inner lumen and coming out, and then you're tying it in the outer section of the trachea. Now, these you can apply traction sutures. I will show you shortly what are traction sutures. Traction sutures are applied proximal and also distal to the trachea. They are done for you to hold and also mobilize the trachea. So you can use the traction sutures to bring the distal and proximal end of the trachea together, and then you can put your interrupted sutures. To suture the anastomosis, we use interrupted sutures. Some centers prefer Vicryl, some centers prefer PDS. We normally use a 3 or 4-0 absorbable suture. Yeah? Because once you close the neck, you're not going to be there to remove the suture, so it has to be an absorbable suture. And we usually suture it in a concentric fashion, right? So, in a circular fashion. You can either start posteriorly coming anteriorly, or you can start anteriorly going posteriorly. So that you have an iso-volumetric suture. So, you don't want to suture the left side first and then suture the right side, because if there's a volume mismatch or a cross-sectional area mismatch, then you can adjust it as you suture together, left and right, left and right, left and right, left and right, until you reach the back. So you can adjust the volume discrepancies between the distal and also the proximal trachea. Whenever we suture a trachea, always try to avoid putting your needle through the cartilage. You want to preserve the cartilage as much as possible to maintain cartilage integrity. This is because the cartilage is very important to prevent the trachea from collapsing. If you have a collapsing trachea, whereby the cartilage is non-functioning, that's called tracheomalacia. Yeah, so you don't want that to happen. Yeah? So try to avoid cutting through the cartilage. If you have mucosa below the cartilage, then you take the mucosa below the cartilage. If sometimes there's not enough mucosa below the cartilage, as you will see in your samples later, then you have to take the pipe and superior to the cartilage. Yeah? I will show you all after this. And our main aim is to approximate the mucosa so that there's no leak, and also healing can happen nicely. Any questions so far with regards to the trachea? Okay, so let's start first. So I will demonstrate. Perhaps one of you all can assist me, if anybody wants to assist me. Sure. I'm done with it. Yeah, we will adjourn back to 10 minutes time for the demonstration. Yeah. Okay?